So good morning all. So I will start with my case presentation. I will be talking about the factors which affect the intraocular pressure. Because understanding these factors will help us manage and diagnose glaucoma effectively. I have no financial disclosures. So we know intraocular pressure is the pressure exerted by the aqueous humor within the eye, and the normal range lies between 10 and 21 millimeters of mercury. Remember, it's just a guideline, so what's normal for one person may not be normal for the other. And we know high intraocular pressure is a major risk factor for glaucoma. But it's not just the only one, so there are various other factors as well. So we know that intraocular pressure is basically a balance between an aqueous production and aqueous outflow. So the major primary drainage pathway is via the trabecular meshwork. So let's dive into a few cases. So we have a 40-year-old lady who came to us for a routine eye examination with the best corrected visual acuity of 6.6 and 6, and intraocular pressure was 26 and 27 millimeters of mercury. So this is the anterior segment picture, which was within normal limits, and gonioscopy showed open angles. And the fundus picture was within normal limits. So visual field also normal. So having considered this young lady who came to us only for a routine examination, accidentally her pressures were on the higher end. So would you consider treating this patient, or is there any other parameter that you would do before initiating your treatment?
So let me just stop you for a minute. How many people will not treat this patient? So I assume that the rest of you will treat? Or is this the morning breakfast lethargy? So how many people will treat? How many people will not treat? So there's still some people who have not made up their mind. Okay.
Okay, so next important parameter to be considered is the central corneal thickness. So in this patient was around 620 and 640 microns. So we know that measurement with Goldmann applanation tonometer is most accurate when the central corneal thickness is 520 microns. And remember that thin CCTs will underestimate the intraocular pressure, and thick CCTs, thick cornea, will overestimate the intraocular pressure. So various studies were conducted which said that the relationship between a measured IOP and the central corneal thickness is not linear. So all these numbers, all these correction factors are just estimates at the best. So we have another gentleman who came to us for a routine examination again, had a best corrected visual acuity of 6.6 and 6, and intraocular pressure of 26 and 27 millimeters of mercury. So anterior segment again was within normal limits, and gonioscopy showed open angles, and this is the fundus picture, which was also within normal range. So considering this gentleman who came to us for a routine, again the pressures were high. So would you treat this patient?
So how many people will treat? So I've given you the pressures, she's given you the pressures, she's given you the corneal thickness, and they match. And the pressure is high, 26 and 27. How many people will treat? Okay. The others will not treat? Come on, you have bank balances to take care of also. Okay.
So the next important thing to consider is what is the intraocular pressure in this patient? It was 26 and 27. The second important question should be, how was it measured? So in this patient, it was by non-contact tonometry. And remember, when we did a Goldmann applanation tonometer, it is around 18 and 19 millimeters of mercury in both the eyes. So always try and follow the gold standard method for measuring the intraocular pressure. Remember, when you're dealing with intraocular pressure, it's not just the numbers to be considered, but also the technique is also important. So we have a third case where she's a 45-year-old lady who's known diabetic for 10 years and on regular treatment, presented for a routine checkup, and her best corrected visual acuity was 6.6 and 6, and intraocular pressure was 26 and 27. So this is the anterior segment picture, which was normal except for the shallow chambers, and the fundus was normal. So now what next for this patient to be done?
So how many people will treat? The pressures are high, cornea adjusted pressures are high, and a Goldmann applanation tonometer has been used. What else would you want? Why don't you treat? How many people will treat? Okay, good.
Any other test to be done before starting the treatment? Yes, a gonioscopy is a must for all the glaucoma patients, and when we did the gonioscopy, even on forceful indentation, the angles did not open much. So for this patient, a young lady, known diabetic for 10 years, Considering that the fact that she will undergo repeated multiple dilated fundus examination and pressures were raised, so diagnosis of PSC was made, and finally she had to undergo laser peripheral iridotomy. So the take-home message is ideal. A Goldman applanation tonometer should be done in almost all patients, and remember that CCT adjustments are necessary, as we know that thick corneas will overestimate IOP and thinner corneas will underestimate IOP, and gonioscopy is a must in all the patients who walk into the department as it guides our treatment selection. Thank you.